All right, good morning and good afternoon, everyone. Today we're going to be talking more about vital signs. Hope everyone's had a good weekend. So let's get rolling here. All right. Let's go ahead and get going. Just want to make sure the microphone is working. All right. Last time we talked about temperature, and there are 4 different areas, really 5 now, where we record a temperature. We can do it orally, we can do it rectally, we can do it axillary, which is underneath the arm. We can do it tympanic, and of course, we can do it through the temporal, which is what a lot of places use nowadays. The forehead scanner. The most accurate is rectal. The most commonly used is oral. And that's I think it's being quickly replaced with temporal, but we shall see how this continues over time. The least accurate is the axillary, only because there's too many variables involved when we take an axillary temperature. The patient having their arm securely against their body, the thermometer staying in the position where it's accurately recording the temp. So there's different variables when we take an axillary temperature. On the old style glass mercury thermometers, they are each line is marked 0.2, and then each main marker is marked every 2 degrees. More commonly used are the handheld probes. One oral, typically you have an oral probe and a rectal probe. Nowadays, I think a lot of them are just doing the oral probe, so that's a good thing. You can still purchase the old school digital thermometers from like CVS, Walgreens, whatever. They're still commonly used. They're cheap. They're cheaper than your tympanic or your temporal thermometers, which can be quite pricey. My wife and I, we just bought a new thermometer for our family, and we got one on Amazon, and it had like 4.8 stars, and it was like with 30,000 reviews, and it cost us about $38 to $40. All right, so whereas these can cost $7, $8, $9. So taking a pulse, every time the heart contracts, it pushes blood from the heart through the rest of the body. This is a contraction. This is what we feel when we're taking someone's pulse. Every time the heart beats, you should feel the pulse. Now, we can tell if someone has an irregular pulse. We can tell if someone has a weak pulse or a bounding pulse, which is very, very strong. And when you record the pulse, as far as the number of it, you'll also record the not just the number, but also how strong it is, how weak it is, the quality of the pulse, I should say. A pulse is felt every time the heart beats, more easily felt in arteries that are in close contact with the skin. So when we're talking about the neck, if you feel the indentions in both sides of the neck, and you press against one of them, you should be able to feel your carotid artery, which lies just underneath that area. Also, the radial pulse. This is the one most commonly felt in the wrist. Push on a radial bone, and we can accurately record a pulse that way. The brachial pulse in the form, or in the where the bicep is, and this is what you'll feel for a child. For a baby, we go for the brachial pulse, because we don't go for carotid, because we're not going to get an accurate reading, because an infant's neck is so thick and chubby, then it's hard to really feel the carotid pulse through all that extra skin and that extra fat that's there in the neck. Okay, and we also have femoral pulse as well, which we will use, especially if we're trying to evaluate if a patient with a lower leg extremity injury has a viable pulse in that leg. The pulse should be the same at all sites of the body. So I should be able to feel your radial pulse and get the same feeling and the same quality and the same number as I do, say, from your carotid, from your femoral, from your dorsalis pedis, located in the foot. So we should be able to get it all throughout. Okay, if we're not, then we need to either look at the placements of our fingers. Maybe we're just not realizing it, or we can't feel it, or we have a bigger issue here. Maybe the patient is suffering from poor circulatory system. Maybe there's some decompensation somewhere that is enabling proper blood flow in the lower extremities or the periphery. The pulse is an indication of how the cardiovascular system is meeting the body's needs. Okay, that's why we should have good feeling, good color in our hands, in our feet, in our legs. We have medical conditions that sometimes we don't. We have cardiovascular disease. We have peripheral vascular disease, where we'll have low circulation in the periphery. We see this a lot in patients that are diabetic. Those patients that have diabetes, they suffer from neuropathy, which is deterioration of the nerves in the extremities, but also the deterioration of circulatory in the extremities as well. That's why we see a lot of diabetic patients having circulatory system in their hands and in their feet. And if they suffer a wound on the foot, then it's very difficult for them to heal that wound because the circulation is poor in that. So you can't get proper or adequate blood flow in those lower extremities. That's why if you're diabetic and you suffer a wound to your foot or something, if it's not taken care of and not managed properly, you could possibly have your foot or leg amputated because of the poor circulation to it. The pulse rate is affected by many factors: age, fever, exercise, fear, anxiety, anger, excitement, heat, position, and pain. There's many different factors that can impact someone's pulse rate. Let's take weather. If I have someone that is outside in February, say a patient is found or a patient comes into the hospital in February, they've been outside a lot, and you go to feel their pulse, you may feel a very, very weak pulse because blood is being shunt from the extremities to the core to try and keep the body warm. So before you start getting worried that, oh my gosh, my patient doesn't have a pulse in the radial artery, look at the environment. Have they been outside? Have they been exposed to extreme cold? If so, they are shifting blood from the lower and the upper extremities to the core to try and conserve that heat. Medications can be taken to either increase or decrease a person's pulse rate. There's many different medications out there that can have an impact on pulse rates. If we take a medication that has any stimulants in it whatsoever, that is going to increase the heart rate. If we take any medication that is a depressant, like an opioid or something like this, then we also take the chance of lowering that pulse as well. Pulse sites. We got the temporal there in the temples. We have the femoral, which is right there located near the groin. We have the popliteal artery, which is located behind the knee. We have the posterior tibial, which is located on the inside part of the ankle. We have the carotid, the brachial, the radial, and dorsalis pedis. Excuse me, we will check the dorsalis pedis and the posterior tibial if we have patients that suffer lower leg injuries. You will always take a pulse. Excuse me. We'll always take a pulse in that in that lower extremity before and after splinting that injury. So anytime you are treating a patient that's a lower leg injury, I need to know and establish, do they have good circulation before I splint this? And do they still have good circulation after I splint this? All right, this is mandatory. We've got to make sure this is done. Counting a pulse. We typically count a pulse for 30 seconds. If you want to count it for a whole minute, there's no one saying you can't. Typically, we will count for 30 seconds and then multiply by 2. This will give us a very accurate reading. Will it be 100% accurate as far as when we compare it to someone that actually counts for 1 minute? There could be some deviation from that, but for our purposes, it's going to work. It's going to be close enough. It's not going to deviate from what it actually is by too large of a degree or not. Okay. So count for 30 seconds, multiply by 2. We note the rhythm. Is it regular or irregular? Okay. If I'm feeling the pulse, thump, 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 thump. Okay, that, for my purposes, that's irregular. Okay, it's regular, irregular. So it's irregular, but it's regular. Does that make sense? So if it's happening at the same point every time, we can classify that as regular, irregular. However, if it's all over the place, and I'm feeling thump, 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 there's no rhyme or reason to it, that is irregular. Okay, there is no pattern there. Okay, it's just happening whenever. Okay, chances are the patient is having some sort of dysrhythmia, and we need to figure out what's going on. We also observe the force, the strength of the heartbeat. Is it strong? Is it weak? Is it bounding? Is it thready? So we need to make note of this as well. All this goes into a proper documentation for recording a pulse rate. So we need to know how many times it's beating. We need to know if it's regular or irregular. We also need to know if it's strong, weak, thready, bounding. Okay, thready is very, very weak, and bounding is just like, you can almost see it bounding through the skin. Radial pulse. Most common site used for taking a pulse. It's easy to do that while still having a conversation with your patient. I can record a pulse, I can make contact with the patient, and I can try and calm the patient down all at the same time. Okay. In EMS, and especially emergency nursing as well, this is the one you will use most often. Can be taken without disturbing or exposing the person. Yes, so we want to maintain some modesty for our patients if we can. However, if that patient is a trauma patient, the rule is this: they better be naked by the time they get to the ER. Because you cannot do a proper patient assessment or a patient survey if the patient is clothed. Okay, we've got to get those clothes off. We have to examine the body, because when they get to the ER, guess what they're doing? They're cutting stuff off. So we might as well do it out in the field. Okay, but for a patient that's sitting at home not feeling well, we're going to use radial pulse if we can. Okay, there's that protects the patient's modesty for the most part. Place the first 2 or 3 fingers of one hand against the radial pulse. I use my middle finger and I use my ring finger when checking a pulse. That's the way I was taught. That's the way I've always done it. We do not use the thumb to take a pulse. Okay, we'll talk about that in a second. It doesn't matter if I'm taking a radial pulse. It doesn't matter if I'm checking someone's carotid pulse, femoral pulse. It doesn't matter. Me personally, I always use my middle finger and my ring finger to take a pulse. And then what I'm going to do, if I'm checking someone's radial pulse, I'm going to find kind of where that knob is right there in the wrist. I'm going to press on it. And what I'm doing is basically just compressing that artery against the radial bone. And so therefore, it's allowing me to feel it. I'm going to feel it. I'm going to count for 30 seconds. I'm going to watch my watch. That's why if you're practicing emergency medicine, whether it's a hospital, whether it's on an ambulance, helicopter, whatever, we need to have a watch that counts seconds. Okay? That's, if your iWatch does it, great. Rock on. That's wonderful. However, if it doesn't, you need to get a watch that counts seconds. That is mandatory. I'm going to count for 30 seconds, then I'm going to multiply by 2. Do not use your thumb to take a person's pulse. You can actually feel your pulse in your thumb. So if you're using that, you don't have no idea if you're taking your pulse or the patient's pulse. Okay, so we need to make sure we're using either our index finger and index finger and our middle finger, or our middle finger and our ring finger. Okay. Normal pulse rates, 60 to 100 beats per minute for an adult. Okay, this is the parameter in which we go by. Some places will say 70 to 100. We'll go with 60 to 100. If someone's heart rate is over 100 beats per minute, this is known as tachycardia. Okay, so if you hear someone say, or you hear someone say, the patient's tachy, all they're saying is their heart rate is fast. It's over 100 beats per minute. Okay, now for someone that has a heart rate lower than 60 beats per minute, we're going to use the word bradycardia. Okay, so if you hear someone say he's bradycardic, all they're saying is he has a low heart rate. It's below 60 beats per minute. All right, so we need to know these terms. This is how we talk medically. This is how we relate to the nurse, to the physician, whatever, the medical condition of our patient in regards to heart rate. Now, if we look at children, okay, let's look at the stages of it. Birth to 4 weeks, we're going 80 to 180 beats per minute. Okay, if I have a 2-week-old and I get there and I can only get a pulse of 60 beats per minute, I'm going to start compressions on that baby. Okay, I'm going to start performing CPR on that baby because they are not adequately perfusing. Okay, perfusing is the pushing of blood and oxygen to organs so they still work properly. If that infant is not at at least their minimum, I'm doing compressions on it. The same applies to an adult. If I get on scene and my parameter for an adult is 60 to 100 beats per minute, and I get on scene and my patient only has a heart rate of, say, 48 beats per minute, I'm going to make sure that that's correct. If it is, then I'm starting compressions on that person. Because 48 beats per minute is not enough in order for them to properly perfuse. Okay? 4 weeks to 1 year, 80 to 160. 1 to 2 years, 80 to 130. 2 to 6 years, 80 to 120. 6 to 12 years, 70 to 110. Now we start getting in the range that we're most commonly associated with. 12 years and older, 60 to 100 beats per minute. Okay. Now we have, at the paramedic level, we have medications that we can give to try and keep someone's heart from slowing down too much. Okay. If that doesn't work, then we have to try other means. Counting respirations, counting breaths. One respiration consists of inspiration and expiration. So inhalation and exhalation. That is one breath cycle. Okay. The chest rises during inspiration, breathing in, and falls during expiration, breathing out. Okay. So when you exhale, your chest comes in. Okay. We have something known as paradoxical movement. So if you have what's called a flailed chest, which means 2 or 3 ribs broken in 2 or more places. You have what's called a flail segment. There is nothing except tendons and stuff holding that section of rib in place. And so it's opposite with paradoxical movement. So if you're watching your patient and they're breathing in and you see their chest go in, then that's paradoxical. Okay, so breathing out, if it's doing the opposite of that, what it should, if it's going out when they're exhalating, then that's paradoxical movement, and we need to be concerned about that. Count each time the chest rises. Once again, same with pulse. We're going to count for 30 seconds and multiply times 2. Okay, same technique that we use when we're checking the pulse. Okay, do not let a person know you're counting the respirations. Why? Because they're going to try and alter their breathing rate if they can. They're trying to make themselves appear as as normal as possible, especially if they're scared about going to the hospital. Okay, so they're going to try and adjust their breathing. Okay, so if they know you're counting, then you're not going to get a true count. Do it while you're talking to them. You know, I kind of do it at the same time that I'm taking a pulse. I'll put my hand on the radial pulse. I'm taking their pulse. And what they don't know is I'm watching my watch for 30 seconds, counting their pulse. And then as soon as that 30 seconds is done, now I'm watching their respirations while talking to them, counting how many times they breathe. Okay, and so I can knock both those out in 1 minute. I can take both values, multiply them by 2, and that's what I get. Okay, count after taking a pulse. Keep your fingers on the pulse site. Okay, normal respiratory rate for adult is 12 to 20 breaths per minute. Okay, now it's not uncommon to have someone that's in great physical shape that will breathe, say, 10 times a minute. That's not concerning. What starts to get concerning is when they start dropping below 8 breaths per minute. When they start dropping below 8 breaths per minute, now we're getting concerned. Now I'm going to start checking to see if they're hypoxic, meaning that they're not breathing adequately. I'm going to check their pulse ox. I'm going to try and get them to normalize their breathing. And if I can't, then I'm going to have to start breathing for them, which means I'm going to put a BVM, which is bag valve mask, on their hip face, and I'm going to start breathing for them. Okay. At the paramedic level, if it has to do with an airway issue and they cannot manage their own airway, I can do what's called a rapid sequence intubation, which is I push a drug that paralyzes the patient. I stick the ET tube in their tracheal tube down their throat, and I start breathing for them. Okay, this is an extreme measure, but if the patient does not have a patent airway or a good airway, something they can control on their own, I have to do it for them. Okay. Abnormal respirations, tachypnea. Once again, we use the same verbiage that we do for pulse, tachy. So whenever we say something's tachy, and I'm not saying tacky as in, oh my gosh, that shirt is so tacky. That's not what I'm referring to. Tachy as in fast. Tachycardia, fast pulse. Tachypnea, fast respirations. So we have, for us to perfuse adequately, we need to have proper ventilations. So the quality of our respirations, we need to be able to breathe in nice and normal. Take a good breath in and exhale. Take a good breath in and exhale. If we're breathing too shallow and too quick, we're not properly oxygenating our organs and our blood. So we're going to become what's called hypoxic. Okay, if we're breathing too quick and too shallow. If we're breathing too slow and too shallow, or even too slow and too deep, once again, I'm not able to adequately perfuse and oxygenate the blood and the oxygen in our bloodstream in order to meet the demands of the body. Okay, so we have this fine line that we have to this area we have to stay between for us to get proper oxygenation. Okay, if someone is having difficulty breathing, we say they're in dyspnea, okay, or they're dyspneic. Okay, and this tells people that they're having difficulty breathing. They're having problems adequately oxygenating their body. If they're not breathing at all, they're apneic or apnea. Okay, they have no respiration whatsoever, and I'm doing rescue breathing on them at this point. Hyperventilation, fast and deep respirations. Okay, we see this a lot. Someone have an anxiety attack or panic attack. They have deep and they may have shallow respirations. Okay, or fast and shallow respirations. So you got to look at that. Are they breathing deep, or are they all over the place with their breathing? Is it shallow and just going 90 miles a minute? Hypoventilation, slow and shallow respirations. Okay, once again, you can also blend these together. You can have slow and deep respirations. So just don't focus on it has to be slow and shallow. They can be slow and deep. If the person is breathing 4 times a minute and they're taking extremely deep respirations, this is just as bad as someone breathing 32 times a minute, taking very shallow and rapid respirations. Okay, so we need to be aware of that. Blood pressure. The amount of force the blood exerts against the artery walls. We have one value that is at rest, and we have the other value that is at extreme high pressure. Systolic pressure, the pressure exerted upon the vessels when the heart muscles is in full contraction. So that time when the heart pushes that blood out from the heart through the rest of the body, and that pressure against the vessels, the blood vessels, at contraction is our systolic blood pressure. Okay? We need to understand that. So that is at maximum force in the arteries. That is our systolic. That's the top number we get. Our diastolic is the bottom number. Okay? This is when the heart is in between contractions. This is when it's at rest. Okay? That's why we typically have a lower value for this number than we do for systolic. Okay, if we go off the 120/80 method, then my 80 is the diastolic because that is at rest. However, there are some things that impact both of those. Okay, if I have a diastolic that is extremely high, this concerns me more than a systolic that's high, because this is when your arteries are at rest. And if your diastolic blood pressure is extremely high at that point, well, there's something bigger going on here, and that gives me more concern than a person with a higher systolic. Okay, the blood pressure is recorded as a fraction with a systolic pressure on top and a diastolic on the bottom. Okay, then when we do the 120/80, this is what we're talking about. Okay, systolic, diastolic. BP is measured in millimeters of mercury. Okay, that's so you'll see mmHg. This just says millimeters of mercury. Normal systolic range for an adult, 100 to 140. Average diastolic range, 60 to 90. This can vary. Once again, if your patient is conscious, talk to them. Ask, especially when you're taking their vital signs. What do you normally run? Any patient over 65 years of age, I can almost guarantee you 85% of them will be able to tell you what they normally run as far as blood pressure. Okay, they've had it done so often. Many of them have had certain medical issues where they are used to the blood pressure being taken, so they can tell you what their blood pressure is. So if they're conscious and awake and alert, ask them, hey, what's your normal vital signs? Ask them this after you take it, okay, because you don't want your numbers to be skewed, because it does happen. They may tell you, oh, I always run 128/80. And now you got that in your mind and you're watching the blood pressure cuff. And sometimes our mind tries to trick us and go, oh, well, that's what I saw too. In reality, that's not what you saw, okay? If the patient is suffering from high blood pressure, we call that hypertension or a hypertensive crisis, either one. All right, so if you have a patient whose value, say let's have a patient 160/110. This is a hypertensive crisis. Okay, they are hypertensive. They have a high systolic and they have a high diastolic. Okay, hypotension or a hypotensive crisis means they have a very low blood pressure. We see this after use of certain medications, especially erectile dysfunction medications have a history of plummeting your blood pressure. So if you're called to a patient, especially a male patient that is over 60, 65 years of age, that's a question we need to ask when we're doing our patient assessment is, have you taken any erectile dysfunction medications? Because that can also tell us if they have, this is why their blood pressure may be low. Okay. Factors that impact blood pressure. Age. Blood pressure increases as a person grows older. It's just the way it is. All right. So, as you get older, your blood pressure will fluctuate. Now, there are some people who have tremendous blood pressure even at 70 years of age, and that's great. Okay. That's not always the case, though. So we need to be mindful of that. Gender. Women will usually have lower blood pressure than men. Okay. So whatever gender you're born, that also can dictate how our blood pressures and how our vital signs in general look like. Excuse me. Blood volume. This is big. If you have a patient that is hemorrhaging, if you have a patient that is bleeding, either bleeding internally or bleeding externally, this is going to lower the blood pressure. Now, the pulse is going to be higher, but because they are losing blood volume, there's not enough blood in the bloodstream, in the vessels, we're going to have a lower blood pressure reading. Okay, so we need to be aware of that, especially when patients start to go into shock. We'll talk more about that. Stress. Heart rate and blood pressure increase as the body responds to stress. Okay, so that's why I said if you have a patient that's going into shock, their blood pressure is going to be low, their pulse is going to be high, because their heart's trying to compensate for loss of blood flow, so it's trying to pump harder and faster. But the problem is there's just not enough volume in being returned to the heart for the heart to pump out. Okay. Pain increases blood pressure, so we need to be aware of that. If a patient is, say you respond to a car accident, an MVA, and you have a confined patient trapped inside the vehicle, and you go to take their blood pressure, well, certainly this patient, chances are they're experiencing a certain amount of pain depending on what is injured. So once again, depending on if there's any internal injuries, we could see a high blood pressure reading from the pain alone. Okay. Exercise. We've talked a little bit about this. Exercise will increase pulse rate and blood pressure. Okay, initially, and then it'll come down. Weight. The more obese the person is, the higher their blood pressure will be. That's why obesity is a big crisis that we need to get a hold of, because it can impact the body in so many different ways. Race. Black people generally have higher blood pressure than whites. Okay, it's the way it is. I don't know why. And just the same with sickle cell. Patient, African American community is more prone to suffer sickle cell crisis than the white population is. Diet. A high sodium diet increases the fluid volume in the body. Okay, remember, water follows salt. If salt is being taken in, you're going to hold on to the water. Okay, that's why patients with certain dietary needs have to be on a low sodium diet, so they're not holding on to all this water. Okay, because that can cause swelling, also known as edema. Okay, so medications. Medications can be taken to raise or lower blood pressure. And position, whatever the position is, whether it's sitting up, lying down, this also can dictate what factors we see, what value we see in the blood pressure. Okay, so I'm going to go and stop there for today, and I'm going to open it up for any questions. Actually, if you have questions, I want you to fill out the Google form, which is attached to this same lesson. you're going to answer the questions in the Google form and then ask your questions in there. Okay. This is also how I'm going to start taking attendance as well. Okay. It's just easier for me to do it this way. All right. So I'll read the questions. And if it's a question that's really pressing, feel free to reach out to me via email or remind. All right. Hey, I hope you have a good one, and I'll talk to you soon.